Heidi's going to talk to us now about patient concordance, and we'll put that in inverted commas, though, that word. Their concordance with pressure ulcer prevention interventions. So over to you again, Heidi. Thank you.
Thank you, Sarah. Let me share my screen. Let me know if you can see that okay.
Yeah, that's perfect.
Okay, cool. So, yes, thank you for putting the word concordance in inverted commas, Sarah. We will talk about that in a little bit more. So we want to explore what we think we mean by concordance, and then I want to turn that on its head. So those are my session aims, and hopefully I'll achieve them. I've left them very broad there. Usually, when we're thinking about concordance, and actually more usually, we often use the term non-concordant. We will often find things like this written in the patient's records. Patient refused mattress, patient won't go to bed in the afternoons, patient won't keep their heel offloading boots on, patient won't lie on their side. These are statements that are blaming the patient for the fact they won't do things that we're telling them to do that we think will prevent pressure ulcers. In some cases, we think we know that they will prevent pressure ulcers. And if they're not going to do them, then it's their fault if they get a pressure ulcer. And that's very much where this is coming from. And we will label these people non-concordant. So let's go back to the dictionary again and have a look at what the definition of concordance actually is. Well, concord is actually a noun, and it means agreement between persons, other groups as well, of course. It means to be in agreement or harmony, and discord is a lack of concord or harmony between persons of things. Concordance is a noun meaning agreement, concord, and achieving harmony. If you look for non-concordance in the dictionary, you will not find it. It's not a thing. It's a made-up word that we seem to use in healthcare. And actually, we can't even use the term discordance for this, because if we do that, what we're saying is either the patient is non-concordant, which means they won't do what we tell them, or they are concordant, they will do what we tell them. So we are implying that the patient is either agreeing or disagreeing to follow our directions given by us, the healthcare professional, because we know better, and that is a very paternalistic view of healthcare. What we really need to be aiming to do is think about concordance in its true term, which is actually where you've got us and the person who's affected having a conversation about that risk, if indeed that risk exists for them, and what we think might be the best prevention strategies around that. But we also need to do that in the context of what their understanding of that is, what they feel they want to do around that, and that might be centered on their personal beliefs, previous experiences. There's a multitude of things that might be impacted on their ability or desire to want to be interested in some of these things that we are suggesting to them. And if we get to that place, then that is an example of person-centered, shared decision-making. And that's really what concordance is. Concordance is that we've had a conversation, we've shared our knowledge and our skills and some of the information that we know about what we can do to prevent pressure ulcers. They've listened to that, they've agreed with some of it, they've thought, yeah, I can do that, but I really don't think I can do that. And we've come up with a care plan that has been shared between us. So essentially, we stop saying that people are non-concordant and we work towards having this agreement of concordance. So that's basically the end of my presentation. So that's not taken very long, has it at all? But no, I'm joking, really. What I said was I wanted to turn this on its head a little bit. I want us to all start thinking about this very, very differently. Now, when we start thinking about concordance, we're often coming from a place of here we are, the healthcare professional. These are the things we know that need to happen around pressure ulcers. We know that we need to do an assessment. If we do that assessment and that assessment identifies that that person is at risk, we need to put in the skin bundle. And we also need to give them information about that risk. So we're very much coming at it from this place of ritualistic care, if you like. We know we've got these actions. Some of you might even have documentation that is centered on this, that encourages you to identify that you've done things around these 7 items of care. Lisa Ledger has done some really great work with her PhD around this topic. And these are just some of the quotes from her work. I've put the reference in there, be in the reference list at the end. about what the patients are saying about us when we're talking to them about pressure ulcers. And a couple of them here have said, you know, they go on and on about it, which is quite funny because we probably do. Some of the people are thinking, well, actually, what I'd much rather is that if you actually took some time to sit and talk to me properly about it, show me what it is that I need to do to support myself better, rather than chucking an information leaflet at me, which actually I don't want to read. I can't be bothered to read. I don't have time to read. I haven't got the energy to read. I'm exhausted by everything that's going on around me and my journey of illness at the moment. I'd much rather you spent some time talking to me about it. And I think it's really important for us to look at this work by Lisa. There's a couple of papers now that have been published on this, and I'm sure there'll be more to come, because it can really help us understand the perspective of pressure ulcer prevention from these people. We're also doing a national research study at the moment with the CTRU team up in Leeds around pressure ulcer prevention at home for people with long-term neurological conditions. And we're expecting that we'll get some really rich qualitative data from that study around what are the problems that they face in terms of pressure ulcer prevention at home. So very much want you to step back from this a little bit and think about the perspective from the person's point of view that we're caring for. Yes, we know we have to do these things, but actually, do we have to do them all? And if we can't do them all, what can we do instead? Rather than just chucking one option at them, which very often is the mattress, and going, oh, they don't want that, so that's the end of what I have to do. Couple of documents to point you to. 11 years ago now, there was this was a consultation paper that came out from the Department of Health called No Decision About Me Without Me. Now, I'm sure you're all very familiar with that phrase. That became more and more common to be used in healthcare. And more recently, we've had the shared decision-making guideline from NICE. And most of your organisations, if you're an NHS organisation in England, will be looking at this guideline at the moment and thinking about what they're doing within the context of shared decision-making within your area. Now, quite a wordy slide here, but these are some of the content of that NICE guideline. And I just want to point you to some of the words that we've got in here. Things like a collaborative process, working together to reach a joint decision about care. And that working together involves the person that's affected and us, the healthcare professional. Might also involve people that are involved in their care as well. It's promoting ways for healthcare professionals and people to work together to make decisions about treatment and care. It's including recommendations on training, communicating risks, benefits and consequences. Not just enough, and I'll come back to this, not just enough to say you're at risk of a pressure ulcer, therefore you need to do this. We need to think about that more broadly now, and how we can use decision-making aids, patient decision aids that can help them make a decision, and how to embed that shared decision-making in organisational culture and practices. So this needs to become part of our natural way of supporting the people in our care through their health journey. And I'm sure that a lot of you will start to see more of this in your own organisations. Now, this is very new learning for me. Very recently, I was at the EPUAP conference in September up in Leeds, and McCormack presented this work on person-centred care. Now, this work has been going on for a very long time, but I'd never really seen it presented in this way. And so achieving concordance, because don't forget that's what the title of this was, is a place where there is agreement between us, the healthcare professional, and that patient or resident. But it's not just about the actions that we think should take place in order to prevent that pressure ulcer. It is not just about us ticking those boxes to demonstrate we've done what we should have done and marking with a big red cross of blame when the patient or resident won't do those things. It's much bigger than that. If you look at this circle here, it comes right out to what's called the macro context, and I'll come back to that in a minute. It's about us all working within a culture, and that organisation then will support person-centred care. So it's not as easy as you, the person at the bedside with that patient, trying to do things, because it's a lot more complicated than that. Person-centred practice aims to form and foster healthful relationships between us, the care provider, the person we're caring for, and those significant to them. It's about respecting a person's right to self-determine what happens to them, mutual respect between the both of us, and understanding as well. It requires cultures. And culture's a big thing, cultures of empowerment that foster continuous approaches to practice development in order to enable it. So all of this needs enabling at a much bigger level. So there is a lot more to this than just us, the healthcare professional, and we know best and we know what you should have as the patient. We recognize what's wrong with you. We've got all the knowledge and skills. We've had all the training, and we know what needs to happen to you in order to prevent or fix that. And the patient then agreeing to do that is not concordance. So hopefully I've got that little message across to you all. Let's go back to this person-centered framework that has been produced by McCormack and a very large team of other people over a period of many years. This macro context that I've circled here, this is about policy frameworks, strategic frameworks, workforce development, strategic leadership. This is about the whole system and the organisations within those systems. So it's a lot bigger than just us. You can see that we're working into the flower in the middle, but actually in order to get to the place in the middle, we have to have these outer rings working effectively. There are some prerequisites for this to be working in our organisations and for it to be enabled. Those prerequisites are things like the staff need to be professionally competent. And that can be about our interpersonal skills, can be about our clinical skills as well, but it can also be about how we marry those two up, how we have a conversation about what the clinical requirements are, but we've got really good interpersonal skills to do that. And we're coming at it from their space, not ours. It requires a commitment to our job, a desire to want to do this and get it right. We need to have clarity of our own beliefs and values, but also of theirs. And we need to understand, what does self mean? Self can mean many things to many different people. So this is about us. Have a think about, what does self mean to you? What does being a person mean to you? And then maybe you can step back and have a think about, what does a person mean to that patient? We see them as patients. There's a whole life behind that person that we're looking for that we know very little about. As we move further in, this becomes more about the practice environment. So what are the organisational systems that are in place to support person-centred care? How have we got power sharing? Is it very much coming from the board down, or can it come from the ground floor where most of us are working next to the patients up? Even better, what about it coming from the people we're caring for up? Let it start with them. I like this one. You need to have a potential for innovation and risk taking. Now, many of you might just start to put your head in your hands when you're working in the NHS for this, because you can have some really good ideas that you want to put into place, but then you get stuck in treacle as you're trying to implement them, because we're often working in a very risk-averse environment. And actually, when we're thinking about person-centred care and pressure ulcer prevention, we do need to share some risk with the people we're looking after. And we need the organisation to support us to do that. What else is going on in the physical environment that needs to support this? Have we got good skill mix? What are our shared decision-making systems that are in place? And what are our own staff relationships like in our own team, in our bigger teams, in our organisation? So there's a lot of things to think about with this that can impact on our ability to get to that happy, concordant place with our patients. And right in the middle, the outcome that we're aiming for here is something called a healthful culture. And to get there, we've got all these processes and systems around us that are supporting us as the healthcare professionals to start working with our individual patients' beliefs and values, start understanding those, engaging with them a little bit more authentically. And I think Lisa's work highlights the importance of doing that. Are we sympathetically present in the community now? And I'm sure it's the same in the acute setting. It might be very difficult to feel sympathetically present with your people that you're caring for when there's so many other things that you've got to do today. Our community nurses might have 18 visits to do in a space of 6 hours. And some of those Our visits that are about end of life, about leg care, they take a long time. And it's very difficult when you're very rushed to step back and be sympathetically present, especially if it's going to have a knock-on effect with all the other people that you're working to see that day. Working very holistically, that's not just what we think about in terms of a holistical assessment, it's about working holistically within the whole system. So I really like this framework because I think this framework sits really nicely in this conversation about concordance, in inverted commas, as Sarah quite rightly did at the beginning. So to get to this place, then, we need to step back, take a look at the system around us, and we need to recognise that concordance does not mean you say what you do, what we say. That's not what concordance is. Hopefully, you've now recognised that concordance is achieved within a balance of our knowledge, skills and competence and the beliefs, desires and personal choices of the people we're caring for. Somewhere we may find a place of agreement where we can be happy with the care interventions that are acceptable to the person that we're looking after, and that we're supported within our organisation around any level of risk within that agreement. And shared decision making is about informing that decision, providing information to help them make a choice. So when I went to my GP a few years ago, grumbling about my menopause symptoms and lack of sleep and hot flushes and all the things that we go through when we get to that age, I actually found myself having a very balanced, informative conversation with a male GP. He talked through the different treatment options with me. He took time to understand my symptoms. He talked through the risks of some of those treatments. He gave me some practical probabilities of risk around that, whether that was the risk of breast cancer, the risk of other risks such as clots and DVTs. And I found myself able to have a very informative two-way conversation with him about those risks that were based on my history, my family history. And I was able to deduce, and he showed me some information in the BNF and some charts, that my risk of these things was very low. And so with him, I was then able to make an informed choice about the HRT that I was willing to try. When we think about pressure ulcer prevention, though, how much do we inform our patients of that real risk? How many patients in reality do actually get a pressure ulcer in our care? It's actually quite a small percentage. When we think about work such as the Pressure 2 trial that Nixon et al. Did out of Leeds, what their research found is that out of every 50 patients that were allocated an alternating air mattress, one patient would benefit. Are we telling our patients that? We're probably not. Are we telling them you're at risk of getting a pressure ulcer? But in our organisation, 4% of patients will get a pressure ulcer. Those are just things that you might think, well, I don't want to tell them that. They're just going to go, no, I definitely don't want that. I'm willing to carry that risk a little bit more. But if we can understand more about who really is at risk, and I think the Nixon paper also helps us do that, then we can target things more effectively, and we can also have safer, better conversations with those patients that maybe aren't quite as at risk. So thinking about some of the information that you know about the data in your organisation, and perhaps using that as a decision-making aid for people to help them have some informed facts to help them make their decisions. I'm going to focus on the mattress because this is often the thing that everybody thinks is the one thing that we must do to prevent pressure ulcers. We must put them on an alternating air mattress. They have to have an air mattress. They're at risk of having a pressure ulcer. Their Waterlow score is 15, and my policy says if their Waterlow score is 15, I have to put them on an air mattress. You know, it's nonsense, really. And I think Purpose T is going to lend itself much better to us making more informed decisions with our patients about what treatment they actually can have. If Purpose T is flagging orange because they've got a peripheral disease in their lower limb, but actually their mobility is yellow and fine and they can move, where's their risk lying? Do they need an air mattress for that? Probably not, but that might translate in a Waterlow score to something that in your policy tells you do need an air mattress. So we're now going to be able to make better decisions with our patients based on their individual risk factors rather than focusing on a number of a risk score that often can be quite meaningless. And the true risk for that person has got lost while we're looking for that final score. It can help us find compromises and alternatives with them. And we can understand their why and their way not. Their why not. We do need to consider capacity, of course. And for those people that really have not got capacity, then we might need to think about best interest decisions and have conversations with people that know that person really, really well. And I would challenge you to go back and have a look at your local policy and guideline and see what it says about this. How regimented is it in there about what we should be doing with our patients? And have you even got in there about how we work with them to come across what it is they want to do? The other thing the nice guidance have got is another paper on shared decision making around risk assessment, and in there they talk about persuasion. So you might be thinking, okay, I understand why they don't want a mattress, but I'm going to keep persuading them. I'm going to keep having that conversation with them. And what NICE have said is that it's not helpful to use persuasiveness. It doesn't necessarily give a positive outcome in shared decision making because people can still be persuaded to make decisions that aren't consistent with their beliefs and values. And I don't know about you, but this saying of a person convinced against their will is of the same opinion still. I've heard that phrase for many, many years now. And I think it sits nicely in this conversation around persuasion. So we need to be offering decision-making information. Have you created some decision aids that can help people make that decision? I want to just end on a little reminder as well about what is normal human behaviour. And because I think that can also sit in this context, and it helps us to think and move away from looking at our patients as a patient, a person with a problem and a health risk that we can sort out. So let's go back to toddlers. Those of you that haven't had them, well done. Those of you that have, you were probably one once. Those of you that had a toddler who never did this, well, we're all jealous of you. I had 3 boys, and my middle one was an absolute champion at the toddler tantrum. Made absolutely no sense why he was behaving like that some days. We could have a whole conversation in front of a letterbox that would go on and on. Do you want to post a letter? No. Do you want to post? You sure you don't want to post a letter? No. I'd post a letter, and then he would do this. Very easy to drive you crazy as a parent, but it's normal behavior. And what these guys are doing at this age is they're testing their own ability to make their own decisions. And it might seem completely illogical to us, and of course it is, but to them, they're just testing, well, how much power have I got here? And I think that's perfectly normal behavior. And a lot of us grow out of that. We can't keep behaving like that. Some of you might have worked with surgeons, however, and may think that they still do behave like that. And we certainly see it in some aspects of sport, don't we, where people do still behave like this. So it's quite normal behavior, actually. And if you put it in the context of, no, I don't want that mattress, that person might have a very good reason for that. I have a patient who's been in and out of our care, comes into our community hospitals when she gets severe urine infections with spina bifida. She will point blank refuse to have an air mattress despite her risk score pointing them towards her needing one. And the reason for that is when she was first given one of those, the mattress immobilized her. She could no longer get herself in and out of bed independently into her wheelchair. She could no longer move herself in bed independently. We immobilized her with the air mattress, and subsequently she developed a pressure ulcer. So quite rightly so, she point blank refuses to go on one now. And that's a reasonable refusal, I would say. The other thing we all like to do is take risks. I mean, we all know Tom Cruise. Here he is on Mission Impossible, hanging off the side of a mountain. Some of you may be aware that he was actually doing that. He likes to do his own stunts. And there's many of us that like to do sports and other activities that can put us at risk. I don't know about you, but I find myself getting trapped in the Facebook videos nowadays of people doing all sorts of wacky things on skateboards and skis and jumping off buildings and all sorts of things. And you think, oh, when they land, they're all making that decision to do those things themselves. And if, like me, you're a bit of a petrol head, then the temptation for speeding when I'm driving is very big for me. So we are all every day making decisions that are probably quite risky for us and our health. Simple things around the home. A lot of A&E admissions are around accidents in the home. Here's one: how to change a light bulb. I decided I'd Google that, and here there are clear instructions here about how to change a light bulb. Now, I don't know about you, but I don't put a hard hat on. I certainly don't climb up a ladder, and I don't go to the fuse box and turn it off. Some of you might be more risk averse than me, and you may well do those things. I tend to get a chair, balance on it precariously, and lean up and unscrew the light bulb, make sure the light switch was off, so I don't want the new one glaring me in the face, and then put the new light bulb in. So we're all doing things on a daily basis. These are normal behaviours. We all have the right to say no, and we all have the right to make unwise decisions. And what we think is an unwise decision for one person may not necessarily be unwise for them. I always make a joke about all my unwise decisions have been about men. We have the right to make decisions that differ from someone else, and we have the right to have a difference of opinion about things. And we also will all sit there with our own beliefs, including our own health beliefs. So all of this is normal, and I think it sits very nicely within the context of us reaching that space of concordance around pressure ulcer prevention with our patients. And it's nice for us to step back and remind ourselves of this sometimes. So I think I've kept to time on that one, Sarah. I haven't run over. A few references for you if you're interested in those. I don't know if these will be available as a handout, but the references are there should you require them. I'll stop sharing.
Thank you. I'm sorry, I'm still laughing about unwise decisions being about men.
Yes.
Thank goodness my screen was on, because I was like roaring with laughter. Thank you. It was a very sort of light, humorous presentation, but obviously with serious, side to it. But yes, I that's why I said sort of in the inverted commas at the beginning, because I think a lot of the work I do is around lower limb, and we know that patients are always, whenever we get referrals, they're quoting that patients aren't concordant with their treatment, which is usually their compression. And it's like a red rag to a bull to me, so I do a lot around trying to understand why people are struggling with the treatment plan or not being prepared to do it. And I think just that holism, that patient-centeredness that you've demonstrated has been really important. I think you're right. It's around organisations being very risk averse. I've known, people now sort of complete positive risk assessments when people aren't towing the line. I've even known in the past that GPs have drawn up contracts when patients have refused to go into compression, for example, and made them feel as if, that they're just the bad guys. But it is sometimes we have to work with a degree of risk, don't we? Because usually there is a reason why people are finding something difficult or they're not prepared to do that. It impacts massively on someone's quality of life. Like yourself in your example of the lady with spina bifida, I remember going in to somebody's home, and it was only she had MS. She was very disabled with it, lived on her own, and because she had category 4 on her sacrum, she'd been put to bed 24 hours a day, lying on her side, mainly facing the wall, and her quality of life was just horrendous. And she'd accepted it in the end because she thought that was her lot, So there's a huge lot to think about from what you've presented there. Let me just have a quick look in the chat to see if there's any comments. Not at the moment. So I mean, it is that. I mean, it is that very much, isn't it? It's trying to look at that wider picture. But who do you go to around that sort of, when we've got an organisation that's so risk averse, around trying to change that in order for us to be more patient centred? Who makes those decisions? Where does that sit within policy or strategy? How do we change that?
So I think there's a lot of things you can look at there, and it very much depends on what kind of organisation you're working in. So if you're in a care home, you'll very much be thinking about what a CQC going to be saying when they come in. And I think CQC can sometimes be very black and white. They've got so many things that they're considering. They don't always see the little nuances within this kind of thing. And we need to be having conversations with them about this in the pressure ulcer world, I think. If you're working in an NHS organisation, you've probably got a patient safety team, a quality team that you can go to. They should be looking at that shared decision-making document that NICE have come out with now. If you go and have a look at CQC reports for some of the NHS organisations, it's mind-blowing how many times they look at culture within that organisation. So CQC are very much looking at that. And if we look at some of the big investigations that have gone on with some of the other trusts, culture's very much looked at in that. So what have CQC said about the culture in your organisation? If you feel that that culture is in a bad place and not in a place to support change in a positive way around this, then have you got any freedom to speak up? Ambassadors and champions within your organisation, you should have. And it might be that you could go and have a conversation with them as well. So I think see what Tissue Viability are doing in partnership with patient safety and quality teams, see what's going on around shared decision making. In our organisation, we've got a new meeting group that's been set up to look at what we're going to do with shared decision making in our organisation. And it might be that you're not aware that that's happening. And if you're really interested to get involved in that, I would say they really should have people that are down there with the patients at the bedside in those, because they know the difficulties in having those conversations and the challenges that are faced around it. But also, have they got a patient representative on that group as well? What's their perspective on it all?
Yeah, I think
I don't think it's going to happen overnight.
No, but I think the patient voice really helps that, doesn't it? Because sometimes we make assumptions about what people need or what's in their best interest, but actually, unless you've experienced that yourself and have that story, you don't really know.
Yeah.
And I think sometimes there can be flexibility. You know, we used to have like an equipment formulary based on levels of risk, but always reinforce that you have to look beyond that, because that might not be the best for an individual. And rather than just, well, they won't accept it, what else can be done? You know, come back to tissue viability, go to your OT, go to your equipment lead, because often they've got other things up their sleeves, haven't they, to help that, you know, as an alternative to maybe what's being prescribed. Let's have a look at comment here. I agree, it's finding why someone has taken the risk. I looked after a lady who was only 4'10" and the mattress on the bed made it too high. So it reduced her independence and mobility. So it was reviewing the risk. So yeah, it's understanding.
Yeah, absolutely. And it's about, actually, you've got the risk of pressure ulcers. What's your risk of falls with that? So you actually got another risk that you've got to balance there. When we think about safety thermometer, which we don't do anymore, there were 4 harms in there. There was the pressure ulcers, the DVT or the embolus risk, there was the catheter associated infection risk, and there was the falls risk. And I used to say, actually, the other 3 could all impact on pressure ulcers, because if we're taking catheters out, skin will be wetter, increases the risk of pressure ulcers. If we're making them sit still and lie still because their risk of falls is such, increases the risk of pressure ulcers. We're sticking anti-embolism stockings on them and not checking their heels, risk of pressure ulcers goes up. So sometimes we're doing some things in one place to reduce a risk there, but actually it can be increasing a risk somewhere else, and we've got to be aware of that balance.
Yeah. And finally, just a comment here from Iona, you know, agree with the patient-centered care. However, you are bound by current policies, and that's what we've just been saying. Maybe we need to challenge this. However, some new managers are very policy and procedure driven. Common sense and on balance are not always part of their vocabulary. So I think we do have a responsibility just not to accept that necessarily, and to be our patients' advocates, don't we? And to challenge some of these policies maybe, or decisions.
Yeah.
So really fascinating conversation, and I think it's one of those things, conversations are a topic, Heidi, that could be a whole day study day, isn't it? Really, really, really important to remember or talk about patient-centeredness in its relation to their acceptability of treatment plans. So thank you so much for both of your presentations.